A very, very warm welcome on this cold evening to the Soweto Healthcare Hub, and specifically to Apex Surgery Center, who are your hosts this evening. Clearly, unfortunately, when we decided on today as an entity, little did we know that we'd be competing with a once every 4 year phenomena called the Football World Cup. And that's difficult to compete with, so we understand. But we are very grateful for the few of you that have taken the trouble to come out on this cold night to come and hear our address this evening. Our address this evening is exceptionally important because we live in a changing world, and our world continues to change at a rate of knots. From the cars we drive and how we drove them 50 years and their sophistication today, to healthcare, how it's delivered from way back when to how it's being delivered to today, and the way it will be delivered tomorrow. And amongst those many, many changes is the way we are being reimbursed as practitioners, as people at the coalface. Just to digress a bit, when I began practice as a primary care physician, many moons ago, decades ago to be specific, medical aids were established, sort of. Discovery was young. I think it was less than a decade old. And we were reimbursed completely differently. Fascinatingly, when we began day one, and at that time, we used to actually fill in our claim forms by hand on a template. And then we would do something which today you'd consider a miracle. We would take that, put it into an envelope, go to a place called a post office, put it in through a wall, and lo and behold, a week later it would have arrived the other side. And a couple of weeks later, you'd get something which is also a big change in another phenomena today, called a check. This you took to the bank and you were given, or rather your bank was credited for that, and you had to walk into the bank to have that, or to even get your statement. That is how much things have changed on that front. Fast forward to today, obviously, we live in a world of electronic data interchange where you press a button and all the information is gone, received the other side, claims are processed. But within that, and within all of those dynamic changes, as I said, from where we come from, where you'd be paid virtually everything on your claim, now claims are closely scrutinized. Now there's accountability by all parties with regards to the claim. And there are constantly evolving methods of addressing reimbursement in an attempt to make sure that the vehicle that carries us forward doesn't implode. And so there are products like value-based products, there's global fees, and this all stemming from a very, very clear once upon a time situation where you had a fee for service. But I wouldn't like to jump too much into Dr. Madikana's talk this evening. I'd like to introduce him, and he's given me his one-page version of his 12-page CV. I insisted that if I had to read out his whole CV, we might be here all evening. But the synopsis goes like this. Dr. Sivu Madikana is Managing Executive, Healthcare Delivery Transformation and Hospital Risk Management at Discovery Health, with a cross-functional leadership role in commercial healthcare strategy, innovation, and digital transformation. All of those things have a bearing on today's talk. In his role, he leads the development and execution of digital health transformation initiatives, as well as delivery of value-based care models across the provider landscape. As head of hospital risk management, he provides strategic leadership for managing health risk associated with hospital networks, ensuring overall efficiency of care. He is a member of Discovery Health's Risk Executive Committee and Discovery Group Clinical Executive Committee. Like most of us in this room, he's a colleague, medical doctor by training. Steve holds a MBBCH, which tells you where he trained, as well as an MBA and a Master of Public Health from the University of Witwatersrand, South Africa, and New York University, USA, respectively. His diverse experience spans clinical practice and corporate healthcare leadership, including roles as Chief Commercial Officer at First Care Solutions, no relation to our First Care, where he spearheaded new business development, product innovation, and virtual healthcare solutions. His earlier career includes working at the UN in their policy and governance divisions at UN Women in New York, USA, contributing to gender equity initiatives. He is deeply passionate about leveraging innovation, technology, and collaboration to build a sustainable and equitable healthcare system. Without further ado, or jumping more into your convo, let's please give Sivu a warm welcome to the podium.
Yeah, thanks, Don. Good evening, colleagues. I came in a full suit this evening, but internally the weather said no. So I was ready to impress you in a good dress sense. So Godfrey, could you come and help out? Oh, there we go. I promise I won't take us past 7:30. Although I do have 38 slides to share with you. As Don mentioned, the discussion this evening is really around alternative reimbursement models. And I think when you speak around ARMs, there's a number of things that jump to mind to people. And I think just understanding even the basis of the ARMs is important, because when you're speaking around alternative reimbursements over and above the current fee-for-service model, and there's a slide in the presentation that explains that, but it includes things such as fixed fees that we have in the environment. It includes episode fees that we've got with the likes of the coronary artery disease program that we have. We've got global fees as well. And then part of the global fees will also include things like pay for performance. But all of these things are driving, in essence, the idea that the healthcare system is changing and we need to change with it. We need to reimburse appropriately for quality of care and not on a volume basis. And really, this is around the restructure of the healthcare system. We also see a lot of variation within the industry as well, right? Some people bill much higher than others, but the quality outcomes don't link to how much they're billing. And so how do you restructure all of that so that there's equity in the system, but also allows, for sustainability of the ecosystem as well? So really, the presentation this evening is divided into 3 parts. So the one is just explaining our Discovery Health medical scheme experience, which will give you a sense of the sort of trends that we're seeing in the environment. Then we deep dive into cataracts, and we then deep dive into orthopedics, mainly around cataracts and the cataract global fee and the reimbursement structure, and also from an orthopedic perspective, our Discovery Health Arthroplasty Network. Really, this slide highlights for us, and I think what's important is global life expectancy has gone up. Yesterday, we released the Discovery Health Trends 26 report. And what we're seeing from our trends is that Discovery Health members are living much, much longer, which is aligned to what we're seeing globally, right? And life expectancy generally is going up because the quality of life, is also working on aligning. However, when we're looking at global dailies, which are disability adjusted life years, the quality that people are experiencing is much lower, even though they're getting much older. So we're moving away from even just the idea of, longevity, but it's around your health when you're living. So if you're living between the ages of 70 and 90, how healthy are you? Are you able to walk? Are you able to see? Are you able to run? What activities can you do? Um, Interestingly, then, when you look at also, in the middle panel, between 2000 and 2019, and it's been split up between high income countries such as the US, middle income countries, and low income countries, the costs of healthcare have gone up astronomically. And as we might be aware, healthcare costs generally outpace, general inflation in the country, and for a number of reasons. Supply side factors, demand side factors, all contribute to, sort of this imbalance. And so what we're then trying to do is then link, the longevity, link the management of the healthcare costs in order to ensure that there's an equitable healthcare system. What's not in the slide, and something that we usually show in our other presentations when meeting with different doctors and hospitals, is around the fact that the medical aid industry or medical schemes has not grown in the last decade, probably for the greater part of 15 years. Right? We've had the same 9 million members within the healthcare system, both coming in and coming out. And also what you then see in this slide, the graph on your right, I'm looking at it from my left, but on your right, there's that almost teal turquoise line, and you see also a gray line. We're comparing 2013 to 2022. And what we can see from the graph is the number of people that are younger has reduced on the medical scheme. This is DHMS. So people between the ages of 20 and 40 significantly reduced, and people between the ages of 40 and 70, 80 going onwards has shifted to the right a bit more. And so what we're experiencing is the average age of the scheme is, continually going up. People are getting much older, and so when people get older, the costs also go higher. The young people that were anticipated to, subsidize the older, sicker lives aren't necessarily there, and so healthcare costs continually go up. And so this is an important framing in terms of the discussion. I think we just highlight a few stats here. So in 2015, the average age of the Discovery Health population was 33 years old. It's moved in 2024 to 36 years old, so it's moved by about 2 years. The chronic ratio in 2015 was 19%. So chronic ratio being the number of chronic lives that we've got, people with a chronic condition divided by the total lives within the medical scheme, about 2.7 million people, has shifted from 19% to 27%. That also shows us that the members that are on the scheme are becoming sicker as well, right? And then also just to highlight here on a cost of healthcare per life per month, when treating for similar conditions, when thinking around admission rates, pathology tests, etc., and we're looking here for members between the ages of 35 and about 45, compared to a member on the Discovery Health medical scheme between the ages of 75 and 85. The cost for the 85 and 75-year-old is about 3.5 times higher than the 40-year-old, right? And so when also putting all of these things together, the medical aid schemes are aging because it's a stagnant environment. Young people are not coming in, and it's the same people moving between medical schemes. One will move to Discovery, the other will move to the competitors. But generally, we're all experiencing something similar across the board. And just, I think this one of the last few things here is just highlighting. I think what this slide for us highlights is these are all of our network plans. So across the medical scheme, we've got different plans, comprehensive, saver, and a number of them. And we created what we call network plans in order to assist in the channeling of members to one more appropriate facilities. We'll be able to receive discounts in exchange for the volumes, and in that way subsidize what would have been higher increases for the members. And so the likes of KeyCare is a more affordable plan, the likes of Smart is a more affordable plan, and the likes of Delta, as an example, is an affordable plan. To give an example, we released a new active smart plan targeted at young people to try and attract young people. I think we've got about 27,000 new young people below the age of 30 coming into the plan, and because the plan was priced at 1,800 Rand, right? And so this plan is significantly discounted, the 8,000 versus what someone else might be paying at 10,000 Rand for a similar sort of set of services. However, what we've done is restrict where they can go and the number of benefits that they've got available, but obviously accounting for prescribed minimum benefits. And so what we're trying to do in this arena is, get members to the appropriate plans, but also assisting them in the affordability of the plans. And so what we've seen here is more than 50% of new members that are joining Discovery Health Medical Scheme are members that are joining on network plans, which says to us there's a difficulty in affordability in the environment, right? Macroeconomic pressures, inability to work, unemployment, and a number of other issues that are taking place. And so this is an indicator for us around the macroeconomic circumstances that that face the country. And then this slide really just illustrated, we found it an interesting slide that Prof. Roseanne Harris had shared with us previously on a number of our collaborative listening sessions across the country. It's called a cube within a cube, right? And in essence, what this explains, and even if you think around the idea of a national health insurance, the red box is the current amount of pooled funds. So from medical aids, you pay in your contributions to Discovery Health Medical Scheme. They sit in this box, within the scheme. However, a number of trade-offs have to be made because the box doesn't fulfill the amount of things that people want. And so the trade-offs are, you either look at what benefits are covered, right? So do you include additional benefits for members? Do you cover additional services? Do you extend to non-covered members? And what's the balance between member needs and sustainability? Because that box of pooled funds can't fulfill the whole box, and therefore it will either move in this direction, it will move up, or it will move down. And so that's really around the idea of sustainability within the healthcare system, because unfortunately there's no more money in the kitty bank. It is what it is at the moment. And so how do we find sustainability and longer term sustainability for everyone involved, both for the scheme, both for the members, both for the healthcare professionals, both for the hospitals and the different providers that are available in the industry, making sure that we've got sustainability in this ecosystem. This is a case study, and interestingly, our CEO Ron always reminds me this was the first slide I made when I got to Discovery Health, when Health Squared was just liquidated. Now, Health Squared came into being as a merger between Resolution Health and SpectraMed, 14,000 principal members and 23,000 beneficiaries. And in 2022, they had an average age of 47.1 years, right? That's the average age of the medical scheme, where the industry age at the time was 35 years old. So what they were facing is they had an older population that had come into the scheme more sick. And then what happened is this thing that we call in actual terms an actual death spiral, right? So you get a high average age of your beneficiaries, which means high, chronic disease burden. Higher chronic disease burden means higher utilization. So people are accessing services much, much more. What that does is it aggregates the costs into this environment, reducing your operating reserves, right? And to a point where, and there's a term that we've got called solvency, and solvency is a statutory requirement which needs to be above, I believe, about 25% from a Council for Medical Schemes perspective, which is the amount of reserves that you've got within a medical scheme to allow a medical scheme to pay out to providers once claims are coming in, right? So what happened with these guys is that their solvency fell to about 6%, and then later on to 2.1%. It means they had no more reserves left within what they've got, and the reserves are depleted. And so the Health Squared members had to be distributed amongst, Discovery Health Medical Scheme, James, and a number of other colleagues in the industry. Last year, we had the issue of SUSE HOSMED, which also experienced something similar, where their solvency ratio fell from 36.5% in 2021 to 6.7% in 2025. Again, something similar. Higher age of the medical scheme, higher utilization, depletion of reserves. And they went from having a membership of 67,000 members, and people started leaving the medical scheme because the younger healthy lives don't want to be caught in this environment, and therefore left the scheme to other medical schemes. And they were also put into a rescue process. So this just goes to show, the importance of being able to manage medical schemes appropriately, our fiduciary duty as health administrators on behalf of the 2.8 million lives that we look after for the schemes. And so really this is just I'm not sure why it's not coming up. There we go. This is basically just how our department, myself and my colleague Shauna Davis, she's our healthcare transformation manager in my team, we're divided into sort of this structure within Discovery Health, where we look after hospital contracting, specialty contracting, health professional risk management, clinical policy and medicines. We've got population health management, which looks after our primary care provider strategy, and then we've got healthcare delivery transformation and hospital risk management, which is the area that we belong to, which essentially looks after a number of these innovative initiatives. And so maybe to get into cataracts for a bit, just ophthalmology, what we wanted to highlight here is ophthalmology compares really well across the board. And some of our colleagues may have seen this, but in terms of the costs of ophthalmology, direct costs of ophthalmology are about 1.8 billion rand. So that's the amount of money that's being paid out every year. And when it comes to generated costs, it's about 1.6 billion rand. And in total, about 3.4 billion rand gets paid out from an ophthalmology perspective. And then in terms of spend per discipline, ophthalmologists directly, in terms of the amount of money that gets paid directly to the profession, about 1.7 billion rand. And this, I think this was data from about 2024. But I mean, in terms of the disciplines, it's right in the top 10 for us. And then in terms of as a proportion of scheme spend, it's about 4%. We pay out from a risk perspective about 75 billion rand per annum from a Discovery Health medical scheme perspective. I think I've shown this slide previously in some of our discussions I've had, just around the top DRG spend, and DRG is disease-related groupers. So we group the number of ICDs that we've got to put them into risk categories, and once we've got them into those risk categories, we can either say, for example, these are cataracts, without complications, with complications, with major complications, and that's how we're able to understand the severity of disease when we are doing the billing within the environment. But cataracts cost about 1.3 billion rand in total, in terms of annual scheme risk expenditure. From a CAGR perspective, the spend has gone up by a CAGR of 9%, and the total number of cataract technicians has gone up in the country by up to 30,000 procedures in 2024, by 25% since 2019. Now, our CEO always asks us this question, specifically for these two procedures we're speaking about today: is it a good or bad thing that we're having so many cataract surgeries? It's a good thing, right? Because the members are getting older, they require cataracts, we should be paying out for cataracts, right? So it's a good thing. And so our aim here is to balance what we're seeing from a utilization perspective with managing cost and quality, and that's really the structure around value-based care. One of the things that we're also seeing here is this slide, and I think I want us to focus on the bubbles, right? And the bubbles essentially highlight what we call a residual. And a residual is when looking at the claims expenditure for the scheme and the utilization, so the number of cases that have taken place, how much did the scheme pay out versus what was expected for us to pay out? And there's a number of things that drive that. But what we are seeing is these are the top drivers of residual spend in Discovery Health medical scheme. I believe to the tune of about 2.4 billion rand that's paid out more than expected. So ophthalmology is there, orthopedic surgery is there, physicians are there, cardiologists. And so when looking at these things, we always want to understand, why is the scheme paying out more than expected? And there's a number of reasons behind that. And so this is the slide I was alluding to earlier on around the payment evolution when it comes to, how payments have changed over time. Back in the day, and this slide is taken from the CMS in the US, but really just highlighting this journey where when we had Medicare and Medicaid, and it was only fee for service. Then over time, this has moved, and then we got this thing called diagnosis related groupers, which I was explaining earlier on. Because as much as you're paying out as a funder or a health plan, you also need to receive information in terms of, ICD-10 coding. The ICD-10 coding then says to us that, we are seeing conditions that are less complicated, or are they more complicated. It allows us to stratify the severity of what's going on in the environment. And that allows us to then benchmark how much we are paying out versus what we either should have paid out or not. But then what we've seen is also then the evolution around 2010 to the Affordable Healthcare Act, 2015, a huge introduction around, system-based, value-based care initiatives, specifically from a hospital perspective, where we got into value-based contracting with hospitals. So outside of just paying on a fee-for-service basis, what was created is huge value-based care systems around surgicals, around theater time, around the length of stay and the number of admissions, to understand, are we not over-servicing from a supply perspective versus the requirement from a demand perspective. Then there was expansion around value-based care expansion around 2015 to 20 to present. And then lastly, just the CMS, as an example, introduced the CMS Pay for Performance program, which is something that we're currently introducing right now within the orthopedic environment, where outside of over and above of having this global fee, doctors should be reimbursed and facilities should be reimbursed appropriately for having better quality outcomes, right? It incentivizes good quality outcomes. And where the quality outcomes are bad, and we are seeing, for example, the likes of huge readmission rates, huge revision rates, the performance should be judged against what is being paid out. So that's really where you see the quality component of value-based care. This slide really just highlights for us, the health market inquiry said we need to move away from fee for service, because fee for service disincentivizes working towards quality. Fee for service has also, I'll call them material motive for certain people, but some people are incentivized for higher volumes and not necessarily the quality of care that they deliver to their patients. The World Health Organization, something similar, and also OECD countries had a report in relation to value-based care. And so really, the idea of value-based care is definitely not new, and a recommendation in the environment. This just highlights, a number of the other VBC projects that we've got. CAD Care is an example, and the Surgicom Governance Project. But I just want to highlight around CAD Care. And CAD Care is a program that we've got that was launched in 2022 for coronary artery disease. So what we found in the environment, as an example, in Discovery Health Medical Scheme, was patients were experiencing chest pain, presenting to a facility, from presentation into a cath lab, right? Now, when looking at global literature and global standards, low to intermediate risk patients presenting with chest pain, for example, no previous history of chest pain, no hypertension, no history of other, statins or the requirement thereof, said low risk individuals, put myself as an example, presenting with chest pain to a cardiologist should go through a CTCA, as an example, which is a CT coronary angiogram, right? Which is non-invasive, radiology risk, but non-invasive nonetheless, which then gives you an indication whether this person should go to a cath lab or not. And what we found in South Africa, that was not happening at all. It was, you present with chest pain, 30, how old am I? 38, 38-year-old, presenting with chest pain directly into a cath lab, I get a stent. That stent complicates, the outcome might be good or bad or poorer. And so we had to see a change in this environment. We engaged with the South African Society of Interventional Cardiology. We engaged with SA Heart. We came up with recommendations alongside them, looking at global data and benchmarks to say we could create an episode fee around CAD care. And that CAD care episode fee says, if you as a doctor are seeing a certain type of patient, low to intermediate risk, they should be getting a CTCA. you'll be reimbursed appropriately for that and disincentivized from utilizing an invasive angiogram, which has poorer outcomes at times for members and different complications. And so this was a great example of like collaboration within the societies as well as Discovery Health in order to bring out the CAD care program. And currently, I believe we've got about over 200 cardiologists that are utilizing this CAD care program. Here we just highlight a number of the other initiatives we've got from a VBC perspective. Renal dialysis has a global fee, arthroplasty, CAD care with an episode fee. There's a maternity global fee currently taking place. A quick example there, we've seen in South Africa, in the private healthcare system, the cesarean section rate sits at about 80% plus, right? Where globally it's about 25%. And we know that that should not be happening. But we've created a global fee that we pay with, with obstetricians and the facilities, where we pay for that whole birth right up front, paying for it in different stages, but we've got this global fee. So the mechanism of delivery, we're agnostic to it. But what we do know, what we've seen in the environment from a VBC perspective, is behavior in the environment usually changes towards what should be the norm, right? And so currently, with the 15 births that we've had, 8 of those births have been natural vaginal delivery, whereas previously 80% of them would have been a cesarean section. And so that's sort of the good outcomes that we've seen from a good global fee. And so, this year we introduced the cataract global fee around shared value, where it encompasses a full global fee from a health professional perspective, looking at around the member outcomes, and also looking at from a health insurer perspective, in that all of the parties here should gain value, right? And that's how we looked at this when creating this global fee. And really the global fee then encompasses the full episode of care from a cataract perspective, including ophthalmology fee, anesthetic fee, provider fee from a hospital perspective, that's the facility fee. We include also the GP anesthetist, and it's fully encompassing of what should be in a cataract surgery. And I mean, how we came about this, a number of things that we utilized, what we've got from a claims data perspective, the current billing that takes place in the environment, and understanding. And I mean, both in the examples of cataracts and in arthroplasty, huge variation in terms of what people are billing. Some doctors billing some facilities, at much lower rates, where you get others billing at much, much higher rates, depending on where they practice. But the question was, how do we get this variation into the middle to allow for equity within this environment? And really part of the process has been around engaging with different societies around how we get to a point where we've got quality profiling. So we've got this in a number of different practices. We've got about 9 different practice types that have quality profiles: physicians, pediatricians, obstetricians, surgeons, endoscopy. We've got a quality profile. A number of them, gastroenterology. And really, we want to get to a point, and we engaged with the Ophthalmology Society of South Africa and the South African Society of Cataract and Refractive Surgery about 2 weeks ago, on how we get to a point of being able to create these quality profiles, utilizing the data that we've got from a claims utilization perspective, and the data that we can get, from the submissions. In other areas, as an example, we've got records that we reimburse for. So we've got an endoscopy record. So gastroenterologists, when they've seen their patients through Health ID, they can give us additional data that allows us to track what the quality looks like and monitor the outcomes. And so utilizing all of these mechanisms, we'll be able to create a quality profile as part of this rollout for the global fee. And I really other things just highlighting here, from an ophthalmology perspective, thinking around how do we get clinical practice to a more efficient place in terms of how doctors function within their rooms. And so there's things around clinical quality improvement, and the real big work that's taking place from an AI perspective. There's also robotic surgery taking place. There's also efficiency workflows, within practices, and also how do you allow for, more patient access. And the other suggestion that we've seen globally is around team-based high-volume models, because a lot of our specialists currently in our environment practice as solo practices. But if you moved to a more team-based approach, what would that look like? And then to move on to arthroplasty. So really what the Discovery Health Arthroplasty program is about is it covers elective surgery for unilateral hip and knee replacements. And we've got a number of them in the environment, which are not on the slide, but this is focusing on our multi-day program. And it's a team structured approach, right? Where we've got payment models that include, again, similar to what we've got in cataracts. It includes the surgeon, the assistant surgeon, anesthetist, prosthetic, the hospital, the nursing team, and physiotherapy. For all Discovery Healthcare members, unless it's excluded on this with some of the plans, and following care teams that align with global best practice around the clinical care of these members. Currently, within the arthroplasty program, about 91%, or even more, 91% of slightly more of all unilateral hip and knee replacements take place within this global fee, about 10,600 procedures, right, per annum. And what we've seen, looking at arthroplasty in 2018, 2016, versus what we saw, last year and even now, we've seen an almost 25% reduction in the length of stay, right? And that's important because globally, arthroplasty was moving to a more ambulatory environment, but we weren't seeing those shifts in South Africa. Doctors would do their hip replacement, do their knee replacement, take the patient to ICU or high care. Patient stays in hospitals for 5 to 6 days. Whereas a member, or rather a patient who's appropriate, a patient who is, low number of chronic conditions, I suppose slightly less mobile, but maybe also not obese, no other additional complications. Currently, what we're seeing in the environment is a 1.5-day length of stay, right? There are procedures that are taking place in day surgery centers across the country where patients come in, they do their hip replacement, they're discharged on the same day, they go home. We've even added an extra benefit for our members where you get a home nurse as part of this and virtual physiotherapy as part of this. I think what's also important here is this reduction that we've seen from a readmissions perspective and also revisions perspective. So what is given us in the indication is the procedures taking place within the arthroplasty global fee are of high quality, and they're higher quality than what was in the fee for service. And even comparing fee for service versus the global fee, the quality outcomes speak for themselves. And so really this is what the program is about. And so we've got, again, the Arthroplasty Shared Value Initiative, which looks at, all components. And from a shared value system perspective as Discovery, this is a model that we believe in, that members should gain access to care at the lowest, most affordable price and predictable costs, right? Healthcare providers should have improved quality outcomes, be able to streamline their workflow whilst increasing their financial gain. And then from a health insurer perspective, we want to reduce the cost of care, which is continually rising, but also standardize clinical care across the board without the variation that we've seen, and to reduce the variability that we see in the environment. This slide is almost similar to what I showed previously. I won't dwell on it, but it's major joints is also a high costing factor in the environment. We've seen the volumes also increase, but we've seen the cost per event come down through, managing the variation in terms of what the global fee would be looking like. I think this is the most important slide in terms of how we've put all of this together, right? And so the global fee, again, has been modeled in that it's got 3 models in terms of how we pay out, but also structured, as a proportion across the board for the different components that take part in this. And the global fee models that we've got is as an example, I mean, this is very simplistic. There's many more models in here. However, the one can be hospital led, the other one can be managed care organization led, and but yeah, I think I was meant hospital led or professional led. There's an MCO, and also one is payer led. I'm just realizing I presented this at a UK conference, and so that's why the terminology, like payer, is quite different. Um, and really, from a tariff management perspective, and the current environment that we've got within the global fee, as an example, we've got, if we think around increases for the following year, we have a current tariff, right? And then a tariff percentage increase depending on the utilization, the negotiations that take place. And then you get what we call an effective tariff for the following year, which we then pay out. However, we are moving into a world of outcomes based reimbursement. So some of the things that we're looking at are the likes of readmissions, which we've been part of with certain facilities, where we looked at readmissions. Is it worse than expected? Is it better than expected? If it's worse than expected, then if it's greater than one, then we should be not paying out as much as we would have paid out previously. If it's better than expected, the global fee partners get more than expected or what would have been paid out previously. So it's around reimbursing for a component of these what do you call this, of these different global fees, and how do you reimburse for quality outcomes. Again, to what I was alluding to earlier on, we've seen really good proxy outcomes in terms of, is this global fee working out well? We've seen a reduction in the length of stay. We've seen a movement in terms of the wards that patients go to, right? Again, where we were seeing huge number of patients going to like high care and ICU, which might not be appropriate for some patients. And so for the appropriate patients to actually be going to a general ward. So we've seen these shifts, but even within these shifts, what the global fee has been able to do is protect the professionals, protect the facilities, where the price point hasn't shifted because there's been this movement between general ward and high care. I think one of the things that myself and Shana were defending in the business as well, were being asked by the scheme, like, if we are seeing these huge shifts in movement, because we know a high care unit or high care bed costs much more than a general ward bed, and so does an ICU bed. And so if we're seeing these movements in the different bed types, should we not be restructuring the cost of the global fee? And the answer that we had was no. I mean, we got into this agreement that says this is the price point we're setting, and therefore, the people within the global fee are protected in that. Importantly, I think for Apex, the slide shows us a good component around the shift in the setting of care proportions, where previously patients that stayed in hospital greater than 4 days in 2016 were about 86% of all the members. This has shifted to about 47%. Again, we're seeing this huge shift. We're seeing a shift in terms of less than 2 days and less than, between 2 and 3 days. About 29% of all unilateral hip and knee replacements taking place currently within our environment are discharged within 2 days in the environment. The other thing we've seen is the number of orthopedic surgeons have grown over time. Number of doctors within the network increasingly high, huge numbers in that network. And also they've received additional incentives over time in order to participate in this global fee as time goes on. We've seen good quality outcomes, so readmission rates have gone down. We've seen pulmonary embolus rates also go down, and also things like DVTs as well. From a profiling perspective, Shauna manages this process for us meticulously, where we definitely have good profiles that are coming out on a yearly basis, and we've released them much earlier this year, and so we're able to get or gain an understanding of how the doctors are performing, engage with them, and we do what we call a peer mentor review in this process. We engage with the South African Orthopedic Association. They review the profiles, and then they engage with their doctors to understand what's taking place in your practice, How could we help out? Is there any additional things we could do to understand why your revision rates are high or your readmission rates are high or other complications? From a patient-reported outcomes perspective, these are some of the scores that get utilized when trying to understand knee pain, hip pain, and that sort of movement. And really, when we've seen improvement in health from members that have been part of this global fee. These have increased dramatically over the years. And we're looking at 2020 to 2024 data, 9% improvement, 26% improvement, which means the quality, even within the practice, has been improving drastically. As other patient satisfaction scores and other pain scores have gone down, post-operation within the global fee environment, and patient satisfaction scores are also generally 5% much higher than industry. And really, so the question is where to from here? And currently, we are, with a number of categories across the line, we are in the fee-for-service environment. About 56% of our current spend sits within category 2 and 3, and then the question is, from an orthopedic perspective, we're now moving into this world of currently sharing on the upside risk, and then we'll move into sharing upside and downside risk, where we reimburse for the quality outcomes. And that's really the premise when looking around value-based care. Cost over utilization multiplied by quality gives us that equation. Really, this again is similar to that pay-for-performance model I was speaking about earlier on, where one of the things that we're working on now is utilizing, so not just the utilization data, but looking at things such as readmissions efficiency, revision rate, length of stay efficiency, and relative excess in terms of cost from the global fee. If there's any other generated costs that are not accounted for, getting to a maximum score of 100%. And so these will then be risk adjusted. And this is something we've discussed with SAOA, and they're very comfortable and are saying we should be moving on with the pay for performance model, because good quality outcomes should get reimbursed even better. And that's the end of the presentation.